Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Non-steroidal anti-inflammatory drugs like ibuprofen or naproxen are extremely popular. Do they carry hidden risks for the heart? This is the People's Pharmacy with Terry and Joe Graydon.
Over-the-counter sleeping pills are inexpensive and convenient. Many people rely on PM pain relievers night after night for weeks, months, and even years. Is that a mistake?
When it comes to saving money on drugs, the best bet is to buy generic. Many insurance companies won't reimburse for brand name medications, but what if there are questions about generic quality? Is there a way to save money safely?
Coming up on the People's Pharmacy, pain relievers, sleeping pills, and buying affordable brand name drugs.
First, this news.
In the People's Pharmacy health headlines, heading a soccer ball too often could be bad for the brain. Researchers at Albert Einstein College of Medicine queried amateur soccer players. Over the course of 2 weeks, they reported an average of 40 soccer ball headings. Roughly a fifth of the players experienced symptoms of concussion that were categorized as moderate to quite severe. Some of the neurological complications were attributed to unintentional head impacts, such as a collision with another player. But the researchers noted that symptoms of concussion were independently linked to heading the ball. Players who headed the ball more frequently appeared to be more vulnerable to concussions. The results of the new study were consistent with prior research. In the investigation, neurologists found structural changes in the brains of players who had headed the soccer ball over 1,000 times a year. Coaches and players may need to recognize that concussions after heading are more common than most people think.
Sleep is crucial for healthy brain function. That's the conclusion of a 4-year mouse study that delved deep into the physiology of neuronal connections. The scientists scanned nearly 7,000 synapses in 2 distinct areas of mouse brains. Some of the mice were allowed normal sleep cycles, while others were sleep-deprived. The scientists who analyzed the images did not know which mice got restful sleep and which were kept awake. At the end of the experiment, it was discovered that sleep led to synaptic shrinkage of about 18%. The scientists concluded that nerve cells grow and expand during wakefulness. When animals sleep, the synapses become smaller. This cycling effect appears to encourage normal neuronal growth and recalibration and enhance learning.
Patients own their medical records. Getting access to them has not always been easy, however. In past decades, patient information was stored on paper forms. If a person wanted access to her data, she had to get a nurse or clinical person to find the files and copy them page by page. That was expensive, time-consuming, and often frustrating for everyone involved. That was all supposed to change in the era of electronic medical records. 97% of hospitals and 83% of physicians now rely on electronic health records. A federal guidance from a year ago limited copying fees, suggesting a flat fee of no more than $6.50 for digital health records. State laws frequently permit health professionals to charge per-page copying fees that can be as much as 10 cents a page, even more for scanned images. There may also be additional search and retrieval fees. In practical terms, that could mean a patient would be billed hundreds of dollars for a medium-sized medical record, even though a few keystrokes could print out the entire medical record or transfer it to a thumb drive. The authors point out that electronic medical records should allow for easy and inexpensive reproduction of patients' data.
There is increasing evidence that a very old drug for diabetes called metformin may have anti-cancer potential. Studies suggest that this inexpensive medication may be helpful against prostate, breast, lung, esophageal, and colon cancer. Researchers now report that metformin may also offer other benefits against head and neck tumors. The drug interferes with cancer cells' ability to create energy for growth. Metformin also encourages cancer cell death by disrupting the cancer support system. Because metformin is generally well tolerated and far less toxic than standard cancer drugs, it may become a valuable adjunctive treatment for a variety of tumors.
Women who want to keep their bones strong might wish to follow an anti-inflammatory diet. Analysis of data from the Women's Health Initiative found that women whose diets had the lowest inflammatory potential had less bone loss during the 6 years of follow-up. They also appeared to have a reduced risk of hip fracture. What makes a diet anti-inflammatory? The healthiest diets are rich in fish rather than meat, whole grains, vegetables, and fruit. Diets that follow the Mediterranean pattern or DASH diets fit these criteria and have been shown to benefit overall health. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon. I'm a pharmacologist.
And I'm Terry Graydon. I'm a medical anthropologist. Today we're talking about the stories behind the health headlines. We'll get the details from Consumer Reports on a troubling trend regarding over-the-counter sleeping pills.
And we'll find out about the connection between pain relievers and heart attacks.
But first, do you take a drug that requires exact dosing? Getting too much could be risky, but so could too little. Is it safe to take a generic version of such a medicine?
Many old brand-name medicines have become so expensive that hardly anyone can afford them. But questions have been raised about the quality of some generic drugs manufactured abroad. Is there a way to save money and still get high-quality medicines? To help answer that question, we turn to Dr. Todd Cooperman. He's founder and president of ConsumerLab.com, an organization that tests the quality of supplements on the American market.
Welcome to the People's Pharmacy, Dr. Todd Cooperman.
Thank you. Thank you, Terry and Joe. Thanks for having me on.
Dr. Cooperman, a lot of people have become somewhat concerned about generic drugs. I mean, historically, brand names sort of dominated the marketplace, and that's changed quite a lot over the last 2 or 3 decades, hasn't it?
Yeah, absolutely. Generics were hardly used, over 30 years ago. Then the law changed, and tremendous numbers of generic drugs were approved. Some probably should not have been approved, but here we are, and the FDA has been going up a steep learning curve in terms of how to really approve these drugs.
I think last I've heard, 88% of the medications Americans take are now generics.
It's quite amazing. Certainly there are huge positives to that, tremendous cost savings, and most of those drugs are perfectly fine. But in many cases, they're not really quite up to par, I believe. And, we're finding out about these as time goes on.
Well, it's especially worrisome with what are referred to as narrow therapeutic index drugs. Can you tell our listeners what the NTIs represent?
Sure. So these are drugs where there's a very small window where you really have to get it right in terms of the dosage. If you go a little higher, you can have toxicity. You go a little lower, and it won't be effective. So there's a class of these NTI, narrow therapeutic index drugs, which everyone is very concerned about because you really have to hit the mark right on with these drugs. And if the product is a little bit different than the one you had been taking, that can really throw you off and get you into trouble.
I guess we could call them the Goldilocks drugs because they have to be just right.
Exactly. Right.
Now, there have been a lot of questions raised over the last decade or so with regard to foreign-made drugs. And most of the generics are now being made in China. The raw ingredients are coming from there, or India, and there have been a lot of scandals. So tell us a little bit about what are the narrow therapeutic index drugs that would be of concern, for example, to a clinician, to your colleagues, where if it's too much or too little, the patient might get into trouble.
Popular examples of these drugs are the anti-seizure medications for people with epilepsy. There are a number of those drugs that really have to be managed, very tightly. Synthroid for hypothyroid condition, basically a thyroid hormone. Drugs for lowering blood pressure like Catapress. Then there are drugs for stroke, to prevent stroke like Coumadin, warfarin. These prevent blood clotting. So these are examples of these narrow therapeutic index drugs.
So someone who is concerned might decide, well, I want to stick with the brand name just because I don't want to take any chances and because I've read about these scandals or because my physician is concerned that I should be taking Coumadin instead of warfarin or Lanoxin instead of digoxin. But the prices, Dr. Cooperman, the brand names have just gone through the ceiling. It's almost not affordable, and the insurance companies are not encouraging people to take brand names. They're discouraging them, and they want everybody to be on generics.
Right, and I can certainly, understand their perspective, but certainly there are situations where you probably want to stay with the product that's working for you. I mean, if someone can take a generic and it's working for them, terrific. It's very important that they look at the manufacturer listed on that product. If it is listed, in some states that's not even available. You have to go back to the pharmacist and press them for that information, and always request that generic. But if a generic's not working as well as the brand name and you really need to get the brand name, you're really going to be in trouble from a price perspective unless you kind of broaden your horizon and say, look, these drugs are not only sold here in the U.S., but they're sold in other countries like Canada, the U.K., New Zealand, etc., where the prices on average are about 85% lower for the exact same medication, typically made in the same plant. Everything is the same companies typically as well. And even though the law remains where it is technically illegal for people to get their medication from outside the U.S., the government does not go after individuals for doing that. You do need to have a prescription to do that. And about 15 years ago, I started a group called Pharmacy Checker, which looks at these online pharmacies, makes sure that they are really licensed pharmacies, and compares their prices for free for anyone who wants to look online on pharmacychecker.com.
So tell us, why is it important that these be licensed pharmacies?
You want all the assurances that you get when you go to a pharmacy in the U.S., where you know that if it's a licensed pharmacy, they need to be following good pharmacy practices. They need to be buying their medication from licensed wholesalers. So the supply of drugs is really top-notch, just as it is in a licensed pharmacy in the U.S. So we actually have on staff, for example, a pharmacist who used to oversee the pharmacies in Massachusetts, Kellyanne Barnes, who actually visits many of these pharmacies and constantly goes through their credentials as well to make sure that they are up to snuff.
Now, my understanding is the FDA doesn't care whether it's a licensed Canadian pharmacy or not. If you're buying it someplace other than the U.S. of A., it's against the law, right?
Yeah, it's unfortunate, and every recent president has promised to allow Americans to get their medication from outside the U.S. It's really ridiculous that they're not, because the pharmaceutical companies are sourcing most of their ingredients from outside the U.S., manufacturing these products from outside the U.S. So, we're really buying here in the U.S. products that are made outside anyhow, but the prices are just so much lower because other countries have negotiated the prices down. They have set caps, such as in Canada, on these prices. And unfortunately, in the Obama administration, in terms of getting the health plan passed in the U.S., made a deal with the pharmaceutical industry that's been, written about, basically promising that there wouldn't be this type of price negotiation here in the U.S. So the Americans have, we've become a captive audience for these very high drug prices, unfortunately.
Let me see if I understand this correctly. The FDA basically says, well, you can't trust drugs from abroad.
Unless, of course, they were manufactured there and brought in by a generic drug company, right?
Right. I mean, it seems illogical, doesn't it?
Right. If you do it yourself, you shouldn't trust it, but the industry is doing it all the time. It doesn't make sense. It's unfair. Hopefully things will change. But in the meantime, people can and do, and that's about 4 million people in America currently get their medication from outside the U.S. There have been no problems reported with people doing that. So as long as you're getting it from a licensed pharmacy, such as the ones that we've approved on Pharmacy Checker, there have been no problems reported. And there have even been studies done where researchers have gone out and purchased these medications and tested them. and found them to be just as good as the products sold in the U.S.
Now, of course, these are, again, we're talking primarily about narrow therapeutic index drugs and brand names. So these are, made by companies like Pfizer and GSK and Lilly, and, the list goes on. So they're not like made in some back alley. These are brand name companies. But how much can you actually save if you buy from Canada a brand name that you would buy in the United States?
Sure. A popular example would be Synthroid, thyroid medication, generically known as levothyroxine. You can get it in the U.S., the brand name. It's about $1.87 per pill. You can get it generically in the U.S. as well. It's about 15 to 20 cents per pill. However, the generic doesn't always work quite as well as the brand name. So if someone really wants the brand name, if you get it from Canada through an online Canadian pharmacy, that pill's about 35 cents. So you're going from $1.87 for the brand name to 35 cents for the same brand name medication from Canada. So that's about an 81% savings, and that's very typical for these types of drugs. Another would be like digoxin. The brand name is Lenoxin, and so if someone really wanted to get that, it's about $12, actually $12.50 here in the U.S. per pill. That same pill in Canada from a Canadian online pharmacy would be 75 cents. So you're saving 94%.
That is a huge difference. And we do want to emphasize that we're talking about brand name medications. My understanding is there's little, if any, savings to be had by buying generic medicines from Canada, for example.
They're right. The generic market here, if you find a generic that works for you here, bless you, wonderful, perfect. Because we have one of the most competitive generic markets in the world here. We have some of the lowest prices on generics here. So it typically doesn't make sense to go outside the U.S. if you just want to, if you can get a generic here. Although we do know that there is a lot of, price hikes going on, even with generic drugs now, especially products for like dermatology, where there's like only one company making the product. And in those cases, you can still do better going outside the U.S. and getting that generic outside.
So, Dr. Cooperman, what is the message to our listeners when it comes to narrow therapeutic index drugs and saving money?
If you can get a product in the U.S. that works for you, as well as a brand name medication, and save money, do that. But again, remember the name of the manufacturer and try to always request that particular manufacturer. If you can't and you must get the brand name and it's way out of line in terms of price here in the U.S., you should feel comfortable getting the medication from outside the U.S. from a licensed pharmacy such as those approved by PharmacyChecker.com, where you can save about 85% off the price.
Dr. Todd Cooperman, thanks very much for talking with us on the People's Pharmacy today.
Thanks for having me on again.
You've been listening to Dr. Todd Cooperman, founder and president of ConsumerLab.com. That's an organization that tests the quality of supplements on the American market.
After the break, we'll find out about pain relievers and heart health. The Vioxx scandal alerted us to problems with COX-2 inhibitors.
Cardiologist Steve Nissen just published a big study on Celebrex, ibuprofen, and naproxen. How did they affect the heart?
How effective are non-steroidal anti-inflammatory drugs for relieving pain and quelling inflammation? You might be surprised by the answer.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Redex Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. Online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show is 1067. That number again, 800-732-2334. Online at peoplespharmacy.com.
Tens of millions of people take nonsteroidal anti-inflammatory drugs every day to relieve the pain of arthritis, bursitis, tendonitis, or plain old headache. Ibuprofen and naproxen are available without prescriptions, as Advil, Motrin, and Aleve. Many other NSAIDs, such as celecoxib, diclofenac, and meloxicam, are prescribed. Do these medicines have an impact on the heart?
One of the largest randomized controlled trials ever conducted on this question was carried out by Dr. Steve Nissen and his colleagues. The Precision trial was recently published in the New England Journal of Medicine. Dr. Nissen will explain what they discovered. He's chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He's co-author with Dr. Mark Gilanoff of Heart 411, the only guide to heart health you'll ever need.
Welcome back to the People's Pharmacy, Dr. Steve Nissen.
It's always great to be with you.
Dr. Nissen, you are arguably one of the world's foremost cardiologists. What in the world possessed you to undertake a huge study of pain relievers, for goodness sakes?
Well, the stimulus was the just catastrophic events that occurred with the drug Vioxx that was withdrawn from the market in 2004 because it increased the risk of heart-related complications after 20 million Americans had taken the drug. And we had published the initial manuscript, the initial study in the Journal of the American Medical Association that raised questions about the safety of these new pain-relieving drugs, Vioxx and Celebrex. So the FDA and the company agreed that Vioxx would come off the market, but they left Celebrex on the market because there was less clear whether Celebrex shared the same risks as Vioxx. And we felt that it needed to be studied. You can't jump to conclusions that every drug in a class has exactly the same effects. And so we said, let's do it. And it took a long time. It was very hard, but we did get an answer.
Now, the results of that study, it's called the Precision trial, came out just a few months ago. Why were you surprised?
Well, even before you tell us what you discovered, this was a huge study, Dr. Nissen. It was like the biggest study of its kind ever conducted. Tell us a little bit about the methodology, please.
Well, we knew we needed to study a lot of people because patients, even those with high risk for cardiovascular events with arthritis, 2/3 of the people with arthritis are women, and women have lower heart disease event rates. And we knew it would be very hard, and we were not allowed to enroll the trial in Europe because the European regulators said, we already know the answer. These drugs are all bad, and therefore you can't do the study in Europe. So we had to do this all in the United States at a time when heart disease event rates were falling rapidly, due to better medical care. And so the event rates were not nearly as high as we thought they might be. And that means we needed a lot of patients studied for a long period of time. We also needed 3 different drugs to be studied, which makes the study much bigger than it would be if we had only studied 2 drugs.
Which 3 drugs did you study?
So we studied naproxen, which is sold over-the-counter as the drug Aleve, although it's very important for your listeners to understand we were not studying the over-the-counter doses of these drugs. We were studying the prescription doses. Motrin, also known as ibuprofen, is the generic name, and celecoxib, which goes by the brand name Celebrex. Those were the 3 drugs.
And how many people did you enroll?
24,081 patients.
And I assume divide that by a third, and you get how many were roughly in each group?
About 8,000 per group.
So, surprise. What did you discover?
Well, we thought that Celebrex could well have the same risks as Vioxx. We weren't sure, and so we did the study, and it was monitored by what's known as a Data Safety and Monitoring Board during the trial. So, you want to make sure you take every care to protect patients when you do a study like this. And the Data Monitoring Board said, keep going, and so we did. But we really did think that Celebrex had a very good chance of being worse than either naproxen or ibuprofen.
And you found?
Well, if anything, the safest of the three drugs was the Celebrex. Now, it is also important to understand that we were not studying the very high doses of Celebrex where there had been some suggestion that it might be harmful. There had been some studies that had used as much as 800 milligrams a day, which was not the FDA-approved dose of the drug. We used the FDA-approved doses of the drug, which are 200 milligrams a day for patients with the common form of arthritis, osteoarthritis, and 400 milligrams a day for people with the less common form, the autoimmune disorder, rheumatoid arthritis.
Now, I have to tell you, Dr. Nissen, there has been this movement in medical journals to use this word non-inferior.
Yeah.
And for a lot of people to go, what are they talking about? So here were your conclusions. At moderate doses, celecoxib was found to be non-inferior to ibuprofen or naproxen with regard to cardiovascular safety. What does that mean?
What it really means, and again, this is a statistical term in many ways, it means that within the boundaries that we set, it was not worse than these older, commonly used drugs, naproxen and ibuprofen. But in fact, it was so clearly not worse than. In fact, the trends were generally going in favor of the Celebrex. So, it was from a statistical vantage point just unequivocal that it was not worse than, it was not inferior to these older drugs. I think the thing that perhaps was the most striking is that two other safety factors. We looked at cardiovascular safety. That was the primary intent of the study. But on kidney safety and gastrointestinal safety, it was clearly better for Celebrex. There was a highly significant reduction in the risk of developing kidney complications compared to ibuprofen, which is a drug that an awful lot of people take, and one that I'm actually now considerably worried about. And on GI bleeding, it was safer than either naproxen or ibuprofen. So if you take the not worse than on cardiovascular and the better than on GI and kidney, it looks like it's a pretty reasonable drug. It's now generic, so the price is falling rapidly, so it gives people an option.
Indeed. And one of the interesting things is that starting with the Vioxx scandal, I'll call it that, people were saying, well, naproxen is much safer, and it turns out not so.
Well, and people got it wrong, and we understand how the science went wrong here. There was a hypothesis known as the Fitzgerald hypothesis that suggested that the effect of the drugs on blood clotting factors known as platelets were the reasons why they were causing the events that occurred, the cardiovascular events that occurred with Vioxx. But it turns out that ibuprofen pushes up blood pressure very significantly. To a lesser extent, so does naproxen. And there was really no increase in blood pressure on Celebrex. Now, some of those findings are going to be available in full publications soon. But it turns out that it's not just about blood clotting. It's all of the various things that these drugs do. And I know the two of you, in all the years you've done this, understand this, that drugs can affect almost any organ system. And the reason you have to do these large clinical trials is to look at all of the effects of the drugs and integrate them in order to tell people what is the safest and least safe drugs to take.
Now, we've already established that Celebrex was not worse than ibuprofen or naproxen when it came to cardiovascular health, like heart attacks and strokes, but all of these drugs do pose a risk of heart attacks and strokes. The higher the dose, the worse it is. If you've had a heart attack, the worse it is, that is to say, cardiovascular disease. So What is your take-home message for people who might be at risk of having a heart attack? Do they need to be careful, and what are some guidelines?
I completely agree with your statement. We are not telling people that these drugs are completely safe because we didn't have a treatment group that got a placebo, a sugar pill. So we don't know whether these drugs are worse than placebo, but almost everybody, including me, believes that they are. And so I have a very simple message for people. If you need one of these drugs to be able to function, if you've got bad arthritis and you can't get through your activities of daily living, by all means, you should consider taking the drugs. Pain is a terrible burden for society, and we don't want people taking opiates. As we all know, we have an epidemic of those, of people with, opiate addiction. But take the lowest dose you can for the shortest amount of time you can. Don't take high doses if you can avoid it. Don't take more than you need, and don't take those drugs at all if you don't absolutely need them. In our society, people have come to believe that popping a pill is the cure for all of your ills. And, given the fact that I'm 68 years old, I have a few aches and pains myself. I don't reach for naproxen, ibuprofen, or Celebrex unless I've got some pretty severe pain because I don't want to put myself at risk. And, most of the time, for the kind of minor aches and pains, resting the joint and taking it easy for a day or two is probably a safer approach.
Dr. Nissen, we have learned that ibuprofen, naproxen, diclofenac, meloxicam, all these non-steroidal anti-inflammatory drugs may undermine the cardiovascular benefits of aspirin. What about celecoxib, Celebrex? Is that equally problematic?
Well, actually, it's kind of interesting because in the precision trial that we just completed, there was no interaction between ibuprofen or naproxen and aspirin. It was one of the biggest surprises of the trial. The one thing that almost everybody is certain about is that there's not an interaction between Celebrex and aspirin. So, if you need to be on aspirin because you have heart disease, then Celebrex may have some advantages. If you don't have heart disease, you should not be taking aspirin in the first place because it's not indicated for primary prevention of heart disease.
So Celebrex does not pose a problem if someone's taking aspirin?
That's right. Celebrex does not pose a problem if you're taking aspirin. We don't think that either naproxen or ibuprofen do pose a risk, but we haven't proven that beyond a shadow of a doubt. But in the precision trial, when we looked at people that were taking aspirin when they started the study versus those that were not, there was no evidence of an interference in the effectiveness of aspirin by any of the three drugs that we studied.
Dr. Nissen, one of the criticisms of the precision trial was the high dropout rate.
Yes.
And, I'm wondering about that because I'm assuming that people didn't have to pay for these medications. That is to say, this was a freebie. They were getting free Celebrex, which is a pricey drug, but they were also getting free ibuprofen and free naproxen. They didn't know what they were getting, but it was free. And if they had aches and pains of arthritis, like osteoarthritis or even rheumatoid arthritis, they should have been thrilled to be getting this powerful pain-relieving medicine. And yet, what was it? Almost 69% dropped out.
No, they didn't actually drop out. They stopped taking the medication. About 27% of patients actually left the trial completely, and we were not able to follow up.
But dropped out. Why would they stop taking these medicines? Maybe they're not as effective as we thought they were.
They're not. And, these arthritic disorders are very difficult to treat. And what we learned in this trial, it's very different from the typical cardiovascular trial that we do. These are patients who are anguished, they have daily pain, they have trouble getting through their activities of daily living, they get frustrated, they come in to see their doctor and they say, I am still hurting, I want out, give me something else. I don't want to participate in this experiment anymore. We tried and tried and tried to keep people in the trial over the long period of time that it took to get this answer. We were not entirely successful in doing so. It is a limitation. There's no question about it. Fortunately, the dropout rate was almost identical across the three drugs. That is, the same number of people, just about exactly the same number of people, dropped out regardless of which drug they were taking. But it still does undermine some of the findings because you really want to have 100% of the patients followed for the full length of the study.
Well, this brings up the whole idea of NSAIDs, non-steroidal anti-inflammatory drugs, because if you go back far enough, there were corticosteroids, cortisone-like drugs. And I hate to say this, but a lot of your colleagues were a little promiscuous in the 50s in prescribing drugs like prednisone. Then we learned about their consequences. And then along came drugs like indomethacin, Indocin, and boy, was it popular. And then along came Clinaril, and along came a variety of NSAIDs. And every time a new one came along, the old one faded from view pretty quickly, and the new one became the number one hot seller until another one came along, suggesting that maybe these drugs weren't as good as we had hoped they would be.
They're not as good. In fact, we measured pain relief in the study, and we measured it on a 100-point scale. And the actual reduction in pain was about 13 points out of 100. So call it 13%, if you will. It's very modest. And this idea of jumping on the bandwagon of the latest drug to come along has been going on for a long time in American medicine. I don't think it's good. I tend not to use new drugs unless they have very compelling advantages. I want them to be out there for a while and find out what their advantages and their disadvantages are before I start prescribing them. And so, this herd mentality of jumping on the latest drug, it's a problem in American medicine.
And it sounds like it would be good advice for us as patients not to take the newest and latest drug until there's some experience with what it can do.
Now, it's one thing if it's a drug like the new hepatitis C drugs that can cure, what is potentially a fatal, consequences of hepatitis C. But if it's for something like pain relief, unless there's really compelling evidence that it's a lot better, it's probably better to hold back a little bit and let the drug get out there for a while. And, sometimes we find out things about drugs after they're introduced that we wished we'd known when they were introduced.
Dr. Steve Nissen, it's always a pleasure to talk with you. Thank you so much.
My pleasure.
You've been listening to Dr. Steve Nissen, chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic.
After the break, we'll find out about over-the-counter sleeping pills.
It's estimated that Americans spend nearly $500 million on such drugs each year. How well do they work?
PM pain relievers have become extremely popular. Many people take such drugs for long periods of time. Are there any downsides to long-term use of non-prescription sleep aids?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redx Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. The number is 800-345-7339. The website, uttercream.com.
If you'd like to order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1067. That number again, 800-732-2334. Or you can place your order online at peoplespharmacy.com.
What do you do if you have trouble getting to sleep at night? Lots of people use over-the-counter sleeping pills every night for months or even years. Is that safe? To find out, we turn to Lisa Gill. She's deputy editor of Consumer Reports Best Buy Drugs.
Welcome back to the People's Pharmacy, Lisa Gill.
Oh, thanks so much for having me back.
Lisa, the February issue of Consumer Reports has a cover story, The Secrets to a Great Night's Sleep. And they talk about mattresses, people in pain, perfect pillows, and then warnings about over-the-counter sleep aids. I mean, these drugs seem to be ubiquitous and very popular. What are we talking about?
It's true. They are everywhere. So over-the-counter sleep aids, when we say that phrase, what we really mean are things like ZQuil and Tylenol PM and Advil PM and Sominex and Unisom. And there are dozens and dozens of these products on drugstore shelves. You do not need a prescription to get them. The market is huge for them. It's over $648 million a year, and it's in a growing segment of the over-the-counter drug marketplace. But the one thing that these drugs all have in common is that to induce the effect of sleep, they use a drug called diphenhydramine or doxylamine, but mostly it's diphenhydramine. And diphenhydramine is a very old drug to treat allergies. It's been around for decades and decades, and it gets put into all of these medications, but the reason it's there is because one side effect of the drug is to induce sleep, even though it doesn't work for everybody. But yes, they are absolutely everywhere.
So they're using a side effect as a main effect in this case. Now, the fact that these drugs are over the counter means that a lot of people think they're completely safe. Is that a misconception?
Sure. Well, it would make sense. You would think that anything that is available over the counter at a drugstore is, FDA approved and is safe and effective. And in fact, diphenhydramine is approved to treat short-term insomnia, which is why it's in so many products. But I think one thing that was not very well known about it, despite what its label claims say, often these drugs like ZQuil and others have a claim that says non-habit forming. And this is where things got a little tricky. So about a year ago, we did a nationally representative survey of more than 4,000 adult Americans about whether or not they suffered from insomnia and what they did to treat it. And we actually ran most of those results last year. But when our statisticians went back into the data, we noticed one more thing, and it was extremely concerning, and that's why it wound up in the sleep cover story in the issue of Consumer Reports that's out on newsstands now. And that was that not only did people turn to these over-the-counter medications, usually first straight away, more people did that to cure their insomnia than take a prescription sleep aid of some kind. They were taking it not just like, you're supposed to only take it for no longer than 2 weeks. They were taking it every day, and about 40% of those people who took it every day took it for a year or longer. And that's when things got really scary for us and why we decided to write about it. It started to look to us like, in fact, they were habit forming, despite what they say on the label.
Now, habit forming, that's a loaded term. What the heck do you mean by habit forming? Some people go, oh, addiction.
Sure, right. So it's not physically addictive, but as far as we can tell, this is just based on what American adults have told us, taking it beyond 2 weeks, but actually taking it, a month or 2 months or longer and up into the year range starts to look a lot like psychological dependence. People may be taking higher and higher doses if the effect is starting to wear off. They may feel anxious and feel like they're scared that they won't be able to sleep unless they take the medication. We talked actually to some consumers where that was the case. So it's dependence, habit forming. I mean, I don't know. The main thing is many more people were taking it beyond the 2 weeks on the directions, and that can pose some pretty serious risks.
So the directions say don't take it for longer than 2 weeks. Lots of people are taking it for longer than 2 weeks.
Right.
Why should we worry about that?
Right. Well, a couple of reasons. Besides the short-term side effects of things like dizziness, confusion, something we call the next-day hangover effect, where people are more prone to accidents, even car accidents, but also prone to falling even in their household. The really other serious concern is a long-term use. Even a 60-day window of daily use can set you up for an increased risk of dementia and possibly even Alzheimer's. So that's what you're really trying to avoid, or even just cognition or memory problems that don't reach that level of cognitive impairment or Alzheimer's. That's what you're really trying to avoid by not exceeding that 2 weeks.
Now, of course, you have just gotten the attention of lots of our listeners and potentially millions of Americans who rely on these drugs every night for years. We're talking about the ingredient diphenhydramine, sometimes abbreviated DPH, that's found in, for example, the very popular antihistamine Benadryl. And for those of us who are sensitive to the sedating effects of diphenhydramine, and if we take it during the day as an allergy medicine, it often puts us to sleep. It makes us drowsy. It's like if you're on a trip and you've got allergies and you're looking at Yellowstone and it's a beautiful day, now all of a sudden your brain kind of shuts down and you're going, I'm in slow motion. And it's not a very nice feeling, at least not for me. I mean, some people may find it quite acceptable, but I find that sedating antihistamines during the day are problematic. So the question is, if you take this day in and day out for months or years, and there's this risk of dementia, are you referring to this thing called an anticholinergic activity of this drug?
That is exactly right. So diphenhydramine is part of a large class of medications that you just described, which is the anticholinergic medications. And what they do, they treat a lot of things. Even some antidepressants fall into this category, but so do these sort of old-school antihistamines. And we know that they block a neurotransmitter called acetylcholine, and that's sort of responsible for a lot of the cognitive effects that we see, including this potential risk for dementia and Alzheimer's.
Now, there are people who take pain relievers like Advil and Tylenol and Aleve during the day to ease their aches and pains. And, sometimes if they run out, they might take an Advil PM or an Aleve PM or a Tylenol PM. And, what would be the effect of taking that during the day?
Oh, well, it would absolutely be, if you are prone to the side effects of diphenhydramine, you would experience drowsiness and potentially confusion, and it might be very dangerous for you to get behind the wheel of a car, for example. Usually these medications, you're told if you take one of the PM drugs, a part of the instructions indicate that you need about 7 hours of sleep available to you after you take it. And if you don't do that, if instead you immediately get behind the wheel or you try to operate some other heavy machinery, you are at a much higher risk of accidents. It's scary.
It is scary. And I can just imagine people all over the country being scared and saying, but what am I going to do now? If I don't take this medicine so that I can get some sleep, how am I ever going to get the sleep that I need in order to be at my best? Right,
absolutely, because you're right. Not getting enough sleep and long-term, so what's considered chronic insomnia can be absolutely just as dangerous. That also causes auto accidents, confusion, dizziness, and it causes the other problems that we're talking about. So part of our story, the recommendation really is to, first of all, if your insomnia is lasting beyond 2 weeks and it's getting into several months, you really are a candidate for being considered having chronic insomnia. And at that point, it's time to go to the doctor and have a very honest discussion about what's going on. And there's a couple of very good reasons. One is that you could have another condition that's actually causing your insomnia. Hypertension and heartburn can both cause insomnia, so you'd want to be diagnosed for any of those other conditions. The other thing is the medications that you take can have a side effect of sedation. So it could be that you are experiencing a side effect from something else, or even a side effect that is causing you to be awake, rather, and keeping you up at night. So you'd want to have that conversation. But if it's none of those, then it's starting to look at, well, what can we do to actually treat your insomnia? And the answer is hopefully, probably not another medication. Our Consumer Reports Best Buy Drugs recommendation is to try cognitive behavioral therapy first. It has very good efficacy and very little downside because you're not taking a medication.
What is cognitive behavioral therapy for insomnia?
Sure. So cognitive behavioral therapy is a method by which a trained therapist can use several different kinds of techniques to help you think about and approach differently how you sleep. So you may use a technique, for example, like journaling. You may sort of write out, how things went last night, or how you feel about what happens when you don't get enough sleep. There's a lot of anxiety. People that don't get a lot of sleep or enough sleep suffer often from anxiety when they try to crawl into bed at night because they're worried it's going to happen to them again. It's really hell if you've had it, and if you've had it for a long time, it's horrible. So a therapist really is trained, and it's not the kind of therapy where they're taking you back into your childhood and looking at your family and whatnot. It's really about changing your immediate set of behaviors to see if any of these or a group of these behaviors together being changed can help you sleep better. Even things like how much, sometimes they restrict your sleep to try to help you become more tired. You may also be instructed to turn lights off, stop using the computer a couple hours before you go to bed, limit your caffeine intake, just sort of someone to kind of coach you through this bad period. But it's extremely effective, and actually the evidence that we've looked at indicates that cognitive behavioral therapy not only can give you more time to sleep, actually spending, while you're in bed at night, you can get to sleep faster. And the results of those, that can actually last much longer than when you take a medication. It's a very good approach.
Now, for those of our listeners who say, well, I really can't afford it, or I don't want to do that, they're going, I just want to go to the health food store and buy something natural. So what about melatonin? We've heard that, there are some studies out there that say, well, it could work. It might be helpful. Why not try that or some other dietary supplement?
Sure. So for melatonin specifically, melatonin by far and away is the most popular sort of non-drug product. But melatonin, the studies that we've looked at sort of indicate that it can be effective for people who have jet lag or people who are night shift workers. So if your days and nights are constantly getting turned around and backwards for you, taking melatonin at the time you want to sleep actually can be helpful. So those are two, I would say, important cases. So I don't write melatonin off entirely. But for people who go to sleep at roughly the regular time every night, who don't suffer from jet lag or sleep shift disorder, sleep work disorder, melatonin is not going to be all that helpful. And in fact, in those studies, you could also see the placebo is pretty high too. So I would say it probably acts mostly as a placebo if it works at all. And so that's why melatonin is not a great long-term solution. But again, if you find that you cannot get to sleep for several weeks and getting even into several months, it's definitely time to have a heart-to-heart with your physician.
Any other dietary supplements you would recommend?
No. Unfortunately, no. I wish there were sort of like a magic bullet to fix insomnia, but unfortunately there's not.
And for those people who have been relying on the PM pain relievers to get to sleep at night, or just, one of the over-the-counter sleeping pills, how effective is diphenhydramine? We've read several years ago that it might actually negatively affect the architecture of sleep.
Right. Okay. So it's interesting you should ask that. So not everybody is susceptible to diphenhydramine side effects. So for some people, it may have no effect on helping you go to sleep, which means some people may take additional doses, which can be not a good idea. Definitely do not do that. I'd love to hear more about the study that you just described, but we do know that it doesn't work for everyone because it's a side effect. It's not an active part of the drug.
Lisa Gill, the title of the whole Consumer Reports, the headline story is Secrets to a Great Night's Sleep. Will you share those secrets with our listeners, please?
Sure, I'd be happy to share a few tips to help you get to sleep at night. And one that you may not be too surprised to hear is turn off your television, turn off your phone, and turn off your computer screen 1 to 2 hours before you want to go to bed. There is some pretty good evidence that the blue light that is emitted from the devices in particular, but also the television, keeps the brain active, and it can keep it active long after you turn the device off. So we are big proponents of shutting down all your electronics equipment. And if you want to get creative, some people, we've tried before using the blue filtering glasses. It's like they're like yellow glasses that are they're pretty cheap, but it's definitely worth a try. So that's my first tip. Second tip is no caffeine too close to bedtime. Don't work out too close to bedtime. Make sure that you've got the right amount of light and dark in your room. Lots of people usually sleep better in the dark. The bedroom is the right temperature, and that you've got the right sheets and bed clothing to make you comfortable. Also, go to sleep at the same time every night and wake up during the same time in the morning, if at all possible. And really, truly avoid alcohol and any other sort of illicit medications or illicit drugs. If you think that's going to help you go to sleep, they definitely do not. They actually inhibit deep restorative sleep. So avoid those.
Lisa Gill, thanks so much for talking with us on the People's Pharmacy today.
Thank you.
You've been listening to Lisa Gill, Deputy Editor for Consumer Reports Best Buy Drugs.
We spoke earlier with Dr. Todd Kuberman, founder and president of ConsumerLab.com. We also spoke with Dr. Steve Nissen. He's chairman of the Robert and Suzanne Tomsich Department of Cardiovascular Medicine at the Cleveland Clinic. He co-authored Heart 411, the only guide to heart health you'll ever need. You'll also find a link to his Precision trial from our website.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Red X Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. 800-345-7339. The website, uttercream.com.
To order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1067. That number again, 800-732-2334. Online at peoplespharmacy.com.
And when you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your thoughts on today's show. We'd love to have your feedback. You'll find links to Dr. Nissen's Precision trial, as well as our guides to getting a good night's sleep and saving money on medicine. You'll also find a list of anticholinergic drugs.
And a guide to alternatives for arthritis if you want to avoid those non-steroidal anti-inflammatory drugs. When you visit the site, you can also sign up for our free online newsletter or the free podcast of the show. You can listen at your own convenience or share it with a friend. It's all there at peoplespharmacy.com. Become a friend of the People's Pharmacy on Facebook. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you so much for listening, and please be sure to join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
If you're running a retail business, don't let disorganized order fulfillment cause chaos. Use ShipStation instead. From running a business out of your garage to multiple warehouses, ShipStation is ideal for every phase of your growth. Save time with one login for all your stores and by automating tasks. Plus, you'll get the best shipping rates from global carriers. Calm the chaos with the shipping software that delivers. Start a free trial at ShipStation.com/audio. That's ShipStation.com/audio.